to if you heard about fundoscopy, the patients, a lot of you like will scream in your head, right? Because it's not a simple thing. And, I see anything, not able to see anything. You yourself having a problem or doesn't know your instrument. Yes?
Sorry doktor, dia terputus-putus.
Tak bestnya. Kenapa my line hari ni tak cantik? Kalau I tukar pada
Sekarang Dr. cakap dah okey sikit.
dah okey.
Waktu Dr. explain tadi dia macam lag, tapi sekarang okey clear.
Okay. So I think I kena cakap slow-slow ke? Now clear tak?
Clear.
Alright. Alright. So basically the problem can be because of your instrument, whether you not know your instrument very well, or perhaps the light is not bright enough, ataupun the pupils of the patient is constricted, ataupun patient is very uncooperative. Keep moving the head, something like that. Or other than that, you may try to view the fundus in which that patient has an opaque media, whether corneal opacity ataupun presence of hyphema ataupun ada vitreous hemorrhage. So all these things will affect the view of the fundus. Alright, so why this fundoscopy is important? Because this is the only mean for direct examinations of the arteries and veins in living organism. No other specialties that can see the arteries and veins live, but by doing direct fundoscopy, okay, most ophthalmologists, we can see it, and if you know how to do it well, you can see it, means you are looking directly on the arteries. Okay. So what is most important about fundoscopy? You need to know the important landmark. So the anatomic landmark that you need to know very well is the optic disc. Basically, this is the one that you have to see first when you are doing the fundoscopy. Once you see the optic disc, it is clear to you already, then only you can look at the vessels. So you will follow. Let's say you are going to view the superior temporal vessel. So you need to find here the optic disc, and then you will follow the vessel bit by bit until at the end. Then you will go back to the optic disc again, find another branch, and then follow another branch. Okay. If you only scan up, down, right, and left, you will only see the optic disc and the surrounding area. But when you want to look at the vessels, you have to scan up and then move your head, okay, following the vessels. This is by practice. You have to practice doing it, then only you can really perceive it. Alright. We have two way to view the fundus. So the BIO is the one that we use. For you all, everyone know that this is the direct ophthalmoscope, the one that you need to know very well. Okay, so the advantages of this, it is portable and very easy to use. Okay, you can just put it in your pocket, you can bring it everywhere. You can even try on your colleagues, your roommates, or whoever you want to do it. Okay, so that's why this direct ophthalmoscope is very important. Some more, even though you are in the ENT ward, ORL ward, or you are in neurosurgical ward, or perhaps in medical ward, direct ophthalmoscope is readily available over there. Okay, which means not only ophthalmologists, but all doctors should know how to do direct ophthalmoscope or direct fundoscopy. Okay, the good thing is that we see the optic disc, the vessels, everything is enlarged. But the problem is that the field of view is very small. Means on one at one, by looking with, if you don't move it, you will only see part of the, disc. Someone asking me to enlarge the screen, but this is the largest one. You have to enlarge you adjust your own viewing screen, your window, okay, your Webex window. All right, and
Okay dah doktor, dah clear
then
dah.
the best part is that, all right,
Okay,
okay, and okay, and then the best part about direct fundoscopy is that you will see directly. Okay, you don't need to tukar. The superior is the inferior is the superior. No, what you see is what is it in the patient. So if you are looking up, you are looking at the superior part of the retina. If you are looking downwards, you are looking at the inferior part of the retina. Okay, these are the techniques basically. I need to highlight all these things so that you will not forget. Alright, so the bedside manner is very important for whatever examination you want to perform. So ask for permission from the patients, explain what you are going to do, and make sure your positions with the patients are correct. And most important part about direct fundoscopy, you need to tell the patients that you are going to shine their eyes with a bright light. It may cause some the patient may feel uncomfortable. If let's say they want to blink, just blink, but do not move their eyes. Okay, and tell the patients that you are going to come very near to the face. Okay, so that but it is just for a short while for the procedure. And then we move to the how you handle the instrument. This is the thing that if you do it correctly, the procedure will look smooth and not awkward. Okay, patients also will be very comfortable during the procedures. You need to keep right means right eye, your right hand examining the right eye of the patients. So if you're checking on the left eye, you need to use your left eye and your left hand handling the fundoscope. Your index finger should at all time at the dialer. Because the dialer is the one that you want to change the focus of the lens so that you can see the optic nerve clearer, you can see the vessels clearer. Okay, and then make sure the pupil alignment. You have to keep 3 holes in alignment in which your pupil and then the viewing window of the fundoscope as well as the pupil of the patients. Okay, if you miss one thing, let's say your eyes and the viewing panel is not aligned, so you can't see anything, you are shining at different angle macam tu, so you won't see anything. And you always need to neutralize the lens at 0 before you start the procedure. Okay, a little bit about this one, as I said just now, you need to neutralize it to 0. Basically, if you have normal visual acuity, of course, dial to 0. If you are wearing glasses, but you want to wear glasses during procedure, also set it to 0. But if you are not comfortable wearing your glasses, so you just you have to remove the glasses and adjust the power, the diopter dial according to your prescription. So let's say your power is -8, you have to adjust the dial to 8, but the green color one, the green is minus. Okay. Atau let's say your power is 1, so you put it at 1 minus, because most of the young generation, like for young generation who doesn't have presbyopia yet, most of you having minus power, right? So you choose the green color one. But this is only for those having refractive error. Okay, those who are not, always set it to 0. Those who want to wear glasses at all time, please set it to 0. Alright. Okay. Why is it important? Because sometimes if you don't set it to 0 at first, the examiner may actually adjust it to perhaps 15 or 12, and they want to see whether you are checking your instrument well or not. if you just take the fundoscope and start seeing the patients doing the red reflex without adjusting it, then we know you are not aware the setting that you need to the setting of the fundoscope. Alright, so you need to check the brightness and then you have to adjust the lens power. Right, so this is the technique. It is a revision also. You need to get the red reflex. No red reflex means no fundus view. Okay, the opacity can be on the cornea, can be in the aqueous humor, can be in the lens or in the vitreous. Okay, so remember, if you get the red reflex, then go forward. Proceed with your fundoscopy. Right, optimal working distance. Optimal working distance is that the only you know how near you should go, but we usually the assessor, we know if you are very far you cannot see. There are certain distance, so make sure you practice it well. Some of you have fundoscope, right? So you can do it, you can practice it in the room. Ataupun I'm not sure if you can come to the eye clinic to borrow the fundoscope and maybe practice some more. Alright, and sometimes holding the upper eyelid may help you. Alright, sometimes patient has very small palpebral aperture, so quite difficult. So you may use your other hand because let's say you are examining the right eye using your right hand. So your left hand is free, right? So use your left hand, the fingers, just to lift up a bit of the upper eyelid of the patients. Alright, so make sure you follow the sequence. First, reflex, okay, and then get the optic disc, then check the vessels, lastly examine the macula, and lastly is summarize your finding and tell the patients about the finding. Alright, this is you know this one, right? So at one time you may see only part of it. So at first get the optic disc view, then follow the vessels going up, up, up. Then you go back down to the optic disc, get another vessel branch, go to the inferotemporal, follow, 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 and then go back. Okay, you have to go back, you have to follow. It's the easiest way to do this procedure. And then find the suprarenasal vessels, go back to the optic disc and then look at the inferonasal vessels pula. Then summarize it. This is the summary. Always elicit the red reflex. This is very important. If you don't do it, means you do not know that in the absence of red reflex, no fundus view can be achieved. Alright, so I always tell you the easiest way to get the optic disc is by approaching the patient from temporal at 15 degrees angle, because this coincides with the blind spot area. Blind spot is the site of the optic nerve, optic disc. Alright, so you need to move in closer from the temporal 15 disc. Okay, just follow the reflex. Keep the three holes aligned until you see the optic disc. Okay, so once you see the optic disc, do not move, but use your index finger now to dial, to change the focus power, because usually it's not very sharp, so you have to adjust it. Alright, once it comes into focus, measure the cup to this ratio, mention about the color, alright, and then the margin. Alright, because you know pink is normal, pale is abnormal, and then margin, whether it is ill-defined margin or clear distinct margin, and then the cup to this ratio if you're able to see it. So most of the time, if it is not enlarged, perhaps it's just like 0.3, 0.4. If it is enlarged more than 0.5, you will see it very, very well. Okay, then like I said earlier, scan for the vessels and look at the periphery. Lastly, check the macula. How to assess macula? You should ask the patients to look at you. Means when the patients look at you, means they are looking at the light you are shining to them. Alright, and then comment your finding as you go along. Usually for the this this means running commentary. But for direct fundoscopy, it is bit not nice to talk, giving commentary while you are doing it because you are very close to the patient. So just complete your examination first, then only you present your finding to the examiner. Right. Repeat the same technique on the other eye. Okay. But this one, please, usually the examiner will give a clear instruction. Examine the right eye, or examine the left eye, or examine both eye. So it depends. If the examiner only say examine the right eye, just examine the right eye and stop. Okay. So you have to be fully awake, must be in full GCS. You must be alert to the instruction from the examiner, not only for Ophtal, also the same thing for the other stations. Last but not least, you have to thank the patient and summarize. All right, this is the important things. You need to dim the room. Okay. If the light is on, perhaps you just turn it off. Okay. Sometimes you don't do it. You just proceed, but the examiner will help you turn it off. So in this kind of situations, your mark will be a little bit lower. Right. And then after you elicit the red reflex before you approaching patient just now from the temporal, always instruct the patients to look at distant object. Right, there's no focus over there, but you can tell patient, look straight forward. Don't look at you. You always have to tell patient like that so that there's no accommodation from the patients, because with accommodation, it will affect the refractive error and it will influence the finding and all. Okay, so these three things is the one that you have to pay attention to. Do not forget it. And again, macula. Most of candidates always forgotten to examine the macula. So macula is very important part of the retina. Do not forget it. Okay. But why we do examine macula at the end? Because macula is very sensitive to light. So you don't want to uh, to cause patients how do I say, you want the patients to be cooperative throughout the procedures. So you only examine it at the last step. All right. Now we are at the okay. We finish about fundoscopy. Any questions on direct fundoscopy?
Doctor, I want to ask, in case we during the fundoscopy we cannot visualize the findings, will our marks get deducted?
Of course. Of course, because you have to see, you have to, I mean like same thing like other stations kan. If you being asked to examine these findings, so you have to come up with some finding. If you tak boleh juga, then you just mention your finding lah. Like mention why you cannot get, okay, tell. But most of the times the examiner akan kata tak apa, continue look, continue examine until you get the finding. Alright. So try hard to get the finding. But one thing I can say, I'm not sure about KLE setting. Usually we will take, because you are undergraduates, so we won't take patients with diseases. Diseases means like macam ada dot block hemorrhage very significant ke? No. Usually we want you to get the basic. But because the basics on the optic disc too, that is the first landmark you have to see. Patients may have some abnormality on the optic disc. That one still possible. Alright. But we will make sure the rest of the retina is fairly clear, tak ada apa-apa. Alright. Because that is our aim. But just happen if let's say the patients that we call that day having some finding ke apa, then maybe adalah presence of dot block hemorrhage ke apa. But the setting usually is try to get the the one that is normal finding. But normal finding, the optic disc can be variable, right? Some may have 0.3, some may have 0.4, some may have 0.5, something like that. Okay, is it clear?
Yes, doctor, thank you.
Okay.
Doctor, I want to ask
Mm-mm.
about the cup disc ratio. Actually, how do you like make that ratio? Like, how do you know it's normal or not? How you measure it?
It's just an estimations between the cup and the disc. The cup is the central one. The disc is the surrounding. We go to it later because I'll do some revision on glaucoma later on. Okay, so kita akan tengok the example. But it is actually just a rough estimations. Okay. Any question?
Doktor, so nak tanya. So, for example, for the first time kita nak buat fundoscopy tu, kita tak nampak. Lepas kita boleh ulang ke, doktor?
Tak apa, ulang lah.
Okay, doktor.
If
Thank you.
let's say you can't, if let's say you are very near to the patients, but then you tak nampak apa-apa. So, but first thing you dah buat red reflex ada kan? So bila red reflex ada, you go near to the patient, but somehow you cannot see anything. Check again, is it the 3 holes just now aligned or not? Or is it now you are shining on the sclera part, on the conjunctival part, not on the pupils. You have to check. Or if it is difficult, go back a little bit behind and then come from one arm length, from 15 degrees angle, go again. Find the optic disc again. Alright, you can find a lot of videos how to perform it in the YouTube to get familiar with the steps. Okay, but for USM KK, I know kita orang dah memang train you all. It's just whether you can find any abnormalities or not. Macam tu saja. Alright, for KLE, I'm not very sure, but I hope that you can practice it. You can look you can find all the videos ke apa semua, but most important the steps. You have to follow the steps in order not to miss anything. Alright? Okay. I think I just continue first. Later on, kalau nak tanya at the end. Alright? Okay, this ocular motility basically also quite long to explain. Alright? But most important is this one. Why it is important to do extraocular movement? Because we want to see any restriction at any gaze atau tak. Okay, so I will not cover this EOM and then all these cardinal gaze positions. Alright, next is pupillary examinations. Okay, so pupillary examination also is very crucial because you have to examine the cranial nerve, right? So one of it is the cranial nerve 2. So this pupillary examination means you are checking the cranial nerve 2 by doing the direct, indirect, and RAPD. Okay, so maybe we just see a little bit of the video. Okay, first. Okay, this is how we examine. Usually kita akan examine the pupil from down. The light is from down. And then this one is taking the direct reflex from temporal side. Okay, after that, supposed to do the consensual, but I don't form it here. And this is RAPD. So we always make sure the light source is at the same distance on each eye. Okay, this one on the left, on the right, and on the left. 3 seconds on each eye. That is RAPD. Okay. Okay, this is confrontation visual field. As for confrontation visual field, you need to make sure the vision is at least clear. That is what screen is for. Checking on the situation. The first one, I ask the patient any diagnosis missing, and then ask the patient to tell the answer. This is the last step, checking the paper. Okay, so we just skip this one. All right, enough about the basic ocular examinations. So you know which part that I highlighted the most, so that is the one that you have to pay attention to for your exams. All right, now we go back to the another topic, okay, that I put early on. We have pediatric, we have acute vision loss and chronic vision loss. So under acute vision loss, we have this leukocoria. So this is the appearance of leukocoria, whereby one eye you can see the blackish area here, the pupils, and another one the pupils appear white. Alright, so leukocoria is the whitish presence of white pupil. Right, so what could be the diagnosis here? What can you think of? Please unmute to answer.
Retinoblastoma, cataract.
Retinoblastoma.
Okay, retinoblastoma, cataract, any other?
Retinopathy of premature.
Okay, yes. All right. So these three is very good already. So you know, let's say at any point of your life later on, bila you become a doctor, you see these white people even in the newborn, right? Because at the first you will be posted in the pediatric as well. So in the pediatric, there will be neonate posting, ICU posting, whereby you can see patients with diseases ataupun even in the when you are in ONG department, before you discharge the baby to the mother, you have to check the baby, the neonates very well. So pay attention to the people. Let's say you can pick up the leukocoria, tell your MO, because sometimes MO also can miss, and we usually MO will be dependent on houseman also to look at this finding. All right, so you know it, tell your MO, tell your specialist, and then you can refer straight away to the Ophtal. All right. So these are the things that relevant history to be inquired. If let's say you see patients with leukocoria, the onset, any family history of leukocoria, means kalau this patient has siblings, the elder siblings ask whether the elder siblings has the same thing or any history of trauma, okay, and then whether any strabismus associated. Okay, you may examine the patient's and the patient's eye is straight, autophoric, but ask the mother whether at home the eye will be squinting ke apa semua. So this is the thing that you need to ask. Alright, so the possible diagnosis is now very good. You have retinoblastoma, congenital cataract, so ROP, retinopathy of prematurity. So this is the possible diagnosis lah. Alright, so diagnosis to confirm. Even we Ophtal we cannot confirm it, even though so even though we are thinking about cataract, we still need to do some investigations to support and to rule out other causes. Okay, so we have to do B scan, and let's say the finding like suspicious of retinoblastoma, we have to proceed with MRI or CT scan. Okay, next is strabismus. A little bit on the strabismus. You know, strabismus is squint. So we have two types, esotropia and exotropia. How do we know it? Look at the corneal reflex. So the corneal reflex should be at the center of the pupil here. So we know that the left eye on both picture is normal because it is at the center. But on the right eye, the corneal reflex is deviated. Here, why it is deviated? It is not actually deviated, but the pupils do move because of the screen. So if it appears like in the above picture, it is esotropia. Below one is exotropia. So same thing, if you have patients with screen, you have to ask about the onset, any family history, and then any history of prematurity, because we need to think of retinopathy of prematurity as well. Okay, and then whether previously patient has leukocoria and already underwent surgery, means already underwent cataract extraction, something like that. Okay, as well as the history of ocular trauma. So what happened if screen is not treated? This is the all possible complications. First is amblyopia. Amblyopia means the vision, even if you give full correction of glasses or contact lenses or buat surgery, everything already done, but the vision still cannot be improved. Okay, so the eye otherwise already normal finding, so that is amblyopia. And then other complication, if it is not treated early, patient will lose osmosis and has poor vision. And most important is poor cosmetic lah. And this poor cosmetic will lead to low self-esteem. Okay. Alright, what are the treatment options for screen? This may not be so important for your exam, but you need to know it because screen, you can see screen everywhere, whether in the younger age group ataupun in the elderly ataupun those in 20s or 30s. So strabismus can be corrected, means screen can be corrected. We just want to align it like the kita kata tayar kereta kan. If it is misaligned, we just send for alignment. Same thing for screen, strabismus. We have rehabilitation for it. For kids, we can do visual rehabilitations, glasses and all to correct. But if the patients already at the age of 20 plus or 15, 16 macam tu ataupun 30, we know that glasses most of the times will not correct it anymore. Okay, maybe patients already developed amblyopia and all. So we can do screen surgery just to get the eye straight. So cosmetically will look present, but the function wise, I mean like if patients already developed amblyopia, the visions will not be corrected even though the eye is straight. But this is the treatment option for screen. Alright, now we go to ocular emergencies, our second part. We done with pediatrics. Now we go to ocular emergencies. So this is actually any ophthalmic emergencies that are immediate threats to the visual system. So if you don't detect it early on, and if you late, patients might suffer of permanent vision loss. Alright, so these ocular emergencies, most of the times kita kata they will lead to acute vision loss, but some of it will lead to slightly later. Acute means like macam sudden ataupun about 3 days after that. The most is 5 days. But after 5 days, kita akan kata subacute vision loss. Alright, if let's say taking longer than that, it may be chronic ataupun progressive. So in ocular emergencies just now, it can be red eye or white eye. Red eye, because the color also red. Red is associated with inflammation. Most of the time it is painful. So what is it? It can be corneal ulcer, blunt ocular trauma, penetrating ocular trauma, chemical injuries, orbital cellulitis. The list may be longer than this, but these are the most important one. And as for painless white eye, alright, patient's eye may be white, but they can have retinal detachment or central retinal artery occlusion. Okay, as you can see here, over the left side here, is the ocular trauma. We have eyelid injury over here. This one also eyelid injury and then become infected. This one already sutured, so it become nice. This one with the nail penetrating. We have hyphema, and here is like kita kata corneal ulcer. It's very bad corneal ulcer, and this is central retinal artery occlusion. Okay. This is not very important right now, but it is good to know that not only for bone fractures yang ada classifications, for ocular trauma, we also have classification, which is we call Birmingham Eye Trauma Terminology System. Okay, other than this, not only about closed globe, open globe rupture, ocular trauma may be associated with corneal abrasion, subconjunctival hemorrhage as well. Okay, so I have to cover this one because in few months time you will inshallah you will graduate and then you will you will be called to do your housemanship, and then you may be seeing all the cases related to ocular trauma as well. So what you need to do, CT scan is very important if you want to diagnose any radio opaque IOFB, intraocular foreign body, or any orbital fractures. Okay, MRI you can't do if like the patient's having anything ferromagnetic. If let's say you are suspecting ferromagnetic injury, foreign body, ataupun if the patients ada pakai apa kita kata braces ke macam tu. So this thing you need to know. And if you suspect the patient's having globe rupture at all time, because you may be the first person examining the patients. Alright, you have to keep eye manipulations at very minimum. Okay. Obviously, I know you will defer gonioscopy, indentation, and everything, but at least all the EOM ataupun you want to really look into the eye by pulling or elevating the upper lid. That one maybe you can defer. Alright. Yes, that's all. Okay, this one I skip. Okay, now this is cornea ulcer. So cornea ulcer may not be directly related to ocular trauma, but it is under ocular emergencies. Alright. So let's say ophthalmologists, we all on call. Our on call is passive, means we can stay home, but we just come to the hospital when we are being called. Alright. Simple cases, maybe iron dust injury, okay, secondary to welding and all. If let's say happen at 10, we can, sometimes we may ask the patients to come later in the morning. Alright. But as for cornea ulcer, no matter what time the referral is, we will go straight to look at the cases because it is an immediate treat. And then even 1 hour delay in examining the cornea ulcer, 1 hour delay of antibiotic loading, it will lead to progressive and faster corneal involvement lah. Not corneal involvement, faster worsening of the condition. Right. Okay, as for cornea ulcer, we have it may be caused by bacterial, fungal, parasitic, viral, sterile. So bacterial, the most common one is Pseudomonas, all right, usually related to the contact lens. Okay, other than that, strep pneumonia also can lead to cornea ulcer. Staph aureus also can lead to bacterial ulcer. Okay, fungal. Fungal is very common, usually secondary to vegetative injury. When we say vegetative, means ada exposure to something like soil ataupun trees. Okay, all that organic matters. Okay, so the organism most of the times Candida. Other than Candida, Fusarium also very common. Okay, then parasitic. What we have as parasitic? Kita ada Acanthamoeba. Okay, so dia pun boleh lead to corneal ulcer, viral, herpes simplex ataupun herpes zoster can lead corneal ulcer as well. And sterile. Sterile means usually no organism causing the ulcer, but due to patients having neuropathic keratopathy, most of the time complications of herpetic eye disease. Okay, so they lost the corneal sensations and patients can easily develop corneal ulcer because of that. Alright. Okay, so most important about corneal ulcer is the risk factor. You need to know the risk factors of developing it. Okay, so contact lens wearer, we know they are at high risk. Other than that, those patients with ocular surface disease, right, such as after chemical injury atau chemical burn, ataupun those patients with dry eyes. Dry eyes means they don't have enough tears. They don't have good quality of tears. Our tears contains immunoglobulin as well, right? So the lack of this, they can easily get the corneal surface is not healthy, and then it put the patients at risk to develop corneal ulcer. Alright, and then other than that, those who use steroid eye drops for a long time, perhaps having allergic conjunctivitis, and then they just buy over-the-counter drugs, okay, in which turn out to be steroid drugs, and in the long run, they are putting themselves at risk to get the corneal ulcer. Other than that, is patients with underlying diabetes ataupun immunocompromised. Right. This is the signs and symptoms. The signs basically what you see here. Signs is the thing that you see. Symptoms is the one that patients reported. So make sure do not confuse between signs and symptoms. If you're being asked about the symptoms of the disease, so the symptom is not, you can't say injected conjunctiva. The symptom is patient's report of red eye or eye redness. And other than that, patients will report blur visions ataupun whitish opacity on the cornea. Okay, you don't say hazy cornea because patients don't see it. You are the ones see the cornea as hazy. Alright. And other than that, as for the symptoms, patient may report about purulent discharges, eye pain, and reduced visual acuity. Okay, as for the signs, whatever you see in the picture. Alright, but as for you all, no more pictures, no more exhibit. So whatever the finding could be in the cornea ulcer will be presented in words. Okay, so first thing to diagnose corneal ulcer, you have to know the symptoms and then look at the risk factor of it. Alright, so what is the most important examinations and investigations? So what I list here is mainly about examination, check the visual acuity, IOP, slit lamp examinations to look for the cells, fluorescent staining, even the eyelid, if let's say ada foreign body entry ataupun suspicious of foreign body entry, and we can do B-scan in order to see the fundus. Right. So as for the management means how to manage the patients. So you may be asked about what is the investigations, okay, ataupun what could be the specimen or sample that you need to send. Okay, patients with corneal ulcer, they have discharge, right? Purulent eye discharge most of the time. And at the same time, patients having corneal opacity. So what is the best specimen to be sent in corneal ulcer in order to get the organism, the correct organism? What do you think? I need answer from you all. Okay, you already see here, right? It's cornea scraping. So it's always cornea scraping for corneal ulcer, right? If you tell about send the eye discharge for grim staining, culture and sensitivity, no, it's not. Eye discharge may be good in the case of conjunctivitis. But in the cornea ulcer, because it's already involved the cornea, we want to know what is the organism in the cornea itself. So we need to do cornea scraping, and always we do not only send for grim staining ataupun FEMA. The most important is culture and sensitivity. So these two always hand in hand together. Okay, janganlah tinggalkan dia. Alright. And then other than that, as for the management, we need to admit the patients for intensive broad spectrum topical antibiotic. It's enough like that, topical antibiotic broad spectrum. You do need to write the names because the antibiotics are a lot. And then always say trace the culture and tailor the choice of antibiotics according to the sensitivity result. Okay, apart from that, we know corneal ulcer is very painful condition. Most of the time, we will control the pain with cycloplegic agents. And sometimes we will give oral analgesia such as paracetamol. And at all time, we have to monitor and control IOP. If the IOP is high, give anti-glaucoma eye drop. Okay, surgery is also part of the management of corneal ulcer. In the case of impending ataupun memang dah ada corneal perforation, so we have to tamponade, right? Because we want to maintain the integrity of the eye as a whole globe. We don't want to have any opening like that. Or other than that, we can do debulking of the ulcer. In the case of fungus, sometimes fungal ulcer is very large and it takes a long time to heal, to resolve. So we may consider doing tectonic penetrating keratoplasty for the patient. So we remove a lot portions of the cornea that is involved, and then after that we have to cover it with cornea graft. Okay, if we don't treat the cornea ulcer, patients is at risk to get, even if we treat, patients still at risk to get scleritis, endophthalmitis, panophthalmitis, okay? And once it heals, all right, patients will definitely develop cornea scarring, right? Unless the ulcer is very small, like pinpoint ulcer at the early stage, if we treat, perhaps patients will recover, heals without any scar. But those yang macam dah evident to our eye, even you shine, you can see, it will heal with scar. And then patients are at risk to get the secondary glaucoma. Okay, this orbital cellulitis, we just go fast on this. You have to differentiate between orbital and preceptal. Alright, preceptal involve only the anterior part of the eye. Kita kata the preceptal area, which is the eyelid, the skin. Okay, conjunctiva may be involved. Okay, it limited to that. But when we talk about orbital cellulitis, it's already involved the deeper structure. Okay, orbital fat may be involved, and then patients may have diffuse cellulitis. It may compress our and at the same time patient may develop orbital abscess, subparietal abscess ataupun cavernous sinus thrombosis. Alright. For orbital and preceptal cellulitis, any injury or any infection nearby the eye can be the risk factor of them developing it. Okay, other than that, intraocular infection, ulcer just not like this. Okay, this is very good for you because sometimes we don't know. Patients with membranous conjunctivitis, they can have swollen eyelid as well. So you don't know if it's orbital cellulitis or is this only preceptal. So always look at this one, the red signs. Orbital cellulitis, patient will have prognosis, diffuse conjunctival injection, conjunctiva, and the eye is not moved, limited. The patients with orbital cellulitis is unwell and feverish, maybe septic looking, whether the patient is pediatric patients or elderly patients, diabetic patients. As for preceptal cellulitis, most of the time patient is well, not much of purulent discharge, EOM will be normal, no proptosis, no chemosis, and patient is well. Alright. Sorry. So this is a little bit about the management. So orbital cellulitis, we need to find out what is the cause. We will admit the patients for intravenous broad-spectrum antibiotic. Need to do CT scan because the cause may be sinusitis just now. And then we have to check also the blood blood profiles. Okay, whether ada risk of infection, whether high total what cell counts ataupun with high blood sugar. Okay, we want to see what could be the potential cause ataupun what putting the patients at risk in getting this orbital cellulitis. And as for Ophtal, we will do daily monitoring of the optic nerve function, which include the RPD, visual acuity, color vision, and visual field. And if let's say we don't know the cause ataupun usually in most cases we will co-manage with ORL and dental because the sinus ataupun dental caries it is the commonest cause for orbital cellulitis. This one is skip. Okay. So why this orbital cellulitis is under ophthalmic or ocular emergencies? Because the complications, all right, it may lead to death. It's not only visual threatening, but it is life threatening as well. Alright, so the ocular complication is listed here, and as for the systemic, patients can develop brain abscess, cavernous sinus thrombosis, and meningitis. That's why you need to really differentiate. It's good to have, even though preceptor cellulitis, you refer to us, you say, saya takut this patient having orbital cellulitis. It's okay. We are happy if you refer to us. We will evaluate further. And as for pediatric, most of the time we will admit them because the septum in pediatric patient is not well developed. They need intravenous antibiotic for a better penetrations and to limit the progressions. Okay, we don't want the preceptor to progress into orbital. Okay, we finish with that part. Last now is our chronic progressive vision loss, which is yang I listed tadi ada diabetic retinopathy and glaucoma kan. Right. I'm not going to share the pictures of diabetic retinopathy, mild, moderate, severe, or PDR. You can find it a lot in the, you just Google it, you can find it, even the classifications, right? And this is classification also. So basically you need to know mild, moderate, and severe, okay, depending on the finding, right? So you need to know the classifications, right? So apart from knowing that this diabetic retinopathy ada non-proliferative and proliferative, you have to pay attention to the diabetic macular edema because macular edema can develop at all stage. Alright, and diabetic macular edema is usually the cause of poor visions. Alright, patients may have cataract, patients may have other problems, but this diabetic macular edema will significantly reduce their visions. Okay, what about the management? No treatment for non-proliferative diabetic retinopathy. We will just observe the patients, giving the follow-up, look for any progressions, and we will only treat the patients at the proliferative stage whereby we noted any new vessels, whether it's at the disc, elsewhere, or any vitreous hemorrhage, and then we will give the PRP laser, pan-retinal photocoagulation laser. But during this stage, if let's say we notice patients having diabetic macular edema, what are the signs supporting it? Usually presence of art exudate on the macula. If just blood hemorrhage on the macula, most of the time it will not cause any problem. It will not lead to edema. But if the exudate already present at the macular area, most of the time it is associated with macular edema. So this is the one that we will treat. So the ocular management for diabetic retinopathy, we have laser treatment. We have 3 types. Focal and grid treatment is for maculopathy or macular edema just now. And pan-retinal photocoagulation is for PDR, proliferative diabetic retinopathy. So as you can see here above, you see it is white, some of it dah ada a little bit blackish. This could be about 2 weeks or maybe 1 week after the laser. Okay. As bila kita review patients perhaps at 3 months, 6 months, 1 year, 5 year, we will not see this focal laser like this anymore. It will enlarge and becomes like this. Okay, usually it become lagi atrophied, hitam and enlarged. That's why some patients after the PRP, they will complain of night blindness because the rods at the peripheral of the retina already sort of macam damage lah. Okay, sebab kita dah bagi laser on the top. So, okay, as for the macular edema just now, it's not only focal and grid laser, we also have another treatment, which is we can give intravitreal steroid injection ataupun intravitreal anti-VEGF injections, or maybe given patients steroid implant. And another one is topical NSAID, okay, non-steroidal anti-inflammatory eye drops ataupun topical Nevanax. So this is the only eye drops that is proven has good penetrations until the vitreous cavity and can reach the macula. The other eye drops, they don't have the capability to cross the lens to go into deep in the vitreous. Okay, so it is very specific topical Nevanet. As for, okay, this one, I cut and paste from CPG Diabetic, whereby I mentioned about the treatment, the systemic treatment. So basically, as for diabetic retinopathy, we have modifiable risk factor and non-modifiable risk factor. As for non-modifiable is the duration of the diabetic. We cannot change it, right? So already diagnosed like 5 years ago, we cannot change it, become 3 years because patients already got it. So that is non-modifiable. Ataupun the family history, the genetic predispositions. Ataupun the age, their race. That one is non-modifiable. But as for modifiable risk factor is the glycemic control. Means the range of the blood sugar, okay, the lipids, the hyperlipidemia, they can control it. It is modifiable. Okay, and then blood pressure, hypertension. We can modify the blood pressure, right, with our medications and all. Alright, so pay attention to whether it is modifiable or non-modifiable. Okay, last of the day today of the revision class is about glaucoma. Alright, okay, this picture is optic disc of glaucoma. Okay, jadinya kalau kat sini, like I said earlier, not sure, I couldn't remember who asked me just now. So how do we measure the ratio between cup and disc? So look at here, the center white here is cup. So the big is disc. Disc is our optic nerve lah. So cup to disc. Roughly, we are cutting the whole disc into 10 segment. Macam straight. Then you just count, perhaps this one berapa. So kalau macam ni, Nik Syakirin, sorry, I just remember your name. Please tell me, what is the cup disc ratio of this?
This one 0.8 betul?
Okay, 0.8 boleh, maybe dalam 0. Nak kata 0.6 macam tak sangat kan, but 0. Okay lah, it's about 0.7, 0.8. Okay, very good. Apa lagi you can see here? Sorry, I just test terus lah. Ingat lagi tak? What are the other findings of glaucomatous optic this year? What is this?
Nasalization of the vessel.
Yes, very good. So all the vessels already shifted to the nasal part here, right? And then what else you can see here? What do we call? Sorry? Binport sign ataupun Binport is too general tau, too layman. Kita guna medical term. Yes, bionating sign. So we have bionating. We don't have notching sign here. Alright. Other than that, what else? We can't really see the lamella dot signs. Sometimes you can see like blackish dots inside the cup here. If you can see that, it is lamella dot sign. Alright. Then just look at the rim. You compare the rim. Rim is in between the cup and the disc. Okay. Do you see semua sama tak? Ataupun ada part yang lebih thin? This kan?
Ada part yang lebih thin.
Temporal part a bit thin, right? So you can say neuroretinal, thinning of the neuroretinal rim. It is also a feature of glaucomatous optic disc. Okay, later kita tengok lagi. Right. Before that, if let's say you got case of glaucoma, if you're being given optic disc of the glaucoma, you have to mention whatever finding is, and definitely you cannot run away from the diagnosis. Okay, in order to put the diagnosis, always remember glaucoma, we have open angle and angle closure. Right, so under these two, we have primary and secondary. Easy like that. If you put it as it is classified into primary and secondary first, it will be a little bit difficult to divide. So the best is divide it into open angle and angle closure so that we know open angle most of the time is painless. Usually patient come because of reduced vision, which is painless, and sometimes we found it during routine screening. But as for angle closure, most of the time patients will come due to eye pain and reduced vision. So when patients complain of eye pain, the eye will be like very injected like this, cornea will be hazy, pupil will be mid-dilated. This is the features of angle closure. So angle closure, painless, open angle, angle closure painful, open angle painless. Once you divide it into this, then it is a little bit easy. So under open angle, there is primary and secondary. So primary, we have primary open angle glaucoma, right? Which is kita akan kata develop after 40 years old. Alright, then we have normal tension glaucoma. The IOP is normal, but the patient has visual field defect, has optic disappearance, just like glaucoma patients. And if let's say we have all the features of the glaucoma, the visual field and the optic disc, but the age is a little bit younger, below 40, maybe at 20, 30, it could be juvenile open angle glaucoma. Alright, so this is under primary. But still we have secondary. What is the secondary cause of open angle? Maybe uveitic glaucoma, means patient has previous history of uveitis, ataupun most of the time is steroid induced glaucoma, because we know there's a lot of over the counter usage of steroid, ataupun ramai our populations, they like to buy all the supplement drinks and they don't know this supplement contain very high steroid inside it. So these patients will develop secondary open angle glaucoma, steroid induced. Okay, all right. So remember the classifications and then please come up with some diagnosis. And then other than that, under angle closure, we also have primary and secondary. As primary, tak ada apa, memang primary angle closure glaucoma. For secondary cause of angle closure, it can be uveitic ataupun neovascular glaucoma. Ini adalah advanced complications of diabetes. And another one is lens induced, whereby the lens is already swollen and then it push forward, it pushing the iris also closer to the endothelium of the cornea. Then patients can develop secondary angle closure glaucoma, ataupun in the case of lens subluxation or lens dislocations. Alright, clear at the classification and diagnosis?
Clear,
Because you are in year 5, you are going to pro exams, so you need to know how to give diagnosis already. Alright, again here, look at this. Let's compare. This is belong to the same patients. Alright, so we know both are enlarged kan? Alright, siapa nak ni? Baojing, ada bau tak here?
Yes, doctor.
Okay, Bao, can you mention what are the features you can see on the right optic disc? You may be asked about, you may given 2 optic discs and then examiner may ask you, what is the features on the right? So you have to know which one is right, which one is left.
So the
Ikut
right
kat
side.
mana?
Okay, Bao?
Yes. So the right side, the cup dip ratio is about 0.8.
Mhm.
And then there's a pale disc.
Jangan cakapnya. The right side.
Then there is a nasalization of the vessel.
Okay.
And then the peripapillary atrophy.
Dia open.
Okay, but it's not very obvious, right?
Yeah.
Papillary atrophy is this one outside the optic disc where you
Cakap
can
right side. Right.
like the color is slightly different from the other part of the retina and it has some blackish thing.
Pelvis.
Other than that,
There's a bionating sign.
Okay, correct. This is it, right? Very
Yeah.
sharp then, right? Superior and inferior. And there is also neuroretinal ring thinning. Okay. Thinning lah basically overall thinning semua dah. And what you can see here. Can you see
The
the
is it lamella
yes. If you
dot
see
sign?
like it will be like patchy, very vague appearance of hole. This is the lamella dot sign. Okay. Here maybe you cannot see, but here you can see. Alright? Okay, very good. So this is about 0.8 and this will be about 0.6 on the left side. Okay, please know the features. Please know how to describe it well. Please know which one is the cup and which one is the disc. Okay, again, I repeat. The cup is the one at the center. The disc is the one outside. Please do not answer it terbalik, vice versa, or else I'm going to be caught by teaching you all wrong things again. Okay?
Sorry doktor.
Ya.
Boleh tak tunjuk yang notching punya sign?
Okay,
Notching.
dekat sini kita tak ada notching. Notching can be a sign, but there's no notching here. If like notching present, okay, you can see like this big vessel. This big vessel, right now you nampak dia macam sharp turn tau. Notching, dia like something like yang ni, satu ni, tapi dia akan macam nak kata dia just akan keluar and that particular area will be very thin. Let's say kat sini, this one you can see thin kan, tapi tak ada vessel. If there is a vessel here, the vessel will like come out straight. At that notching, usually the neuroretinal rim is thinner compared to the rest. Much thinner. Maybe this one thick like this. Dekat sini will be like very thin. And the vessel is there. Kat situ akan ada notching. I don't have the picture with notching here, but you can try find out dekat Google. You'll find one. But what I'm showing here is bionetting. Okay?
Okay doktor.
Alright. Okay. Then, if you're being asked, how do you confirm glaucoma? Remember, how do you confirm means to confirm glaucoma, not the usual examinations. Do not answer visual acuity and RAPD because visual acuity and RAPD, you do it in all patients. You can't give diagnosis based on these two only. Okay, in order to confirm glaucoma, we need to check the IOP because we want to know whether the IOP is high ataupun normal because we have the normal tension glaucoma just now kan. So after that, we need to check the gonio, the angle, gonioscopy, and then we need to check the anterior chamber depth to see whether the anterior chamber is deep or shallow. Alright, so IOP, the angle, and the anterior chamber, whether it is shallow, which is closed, ataupun dia open and deep. And last one is perimetry ataupun visual field and the OCT. So visual field usually kita kata patient will develop field defect and in the advanced stage patient will get tunnel vision. As in the OCT or kidney head, we can see the thinning of the neuroretinal rim, which is more objective. Alright, because if let's say one ophthalmologist saying, I see it as 0.7, another ophthalmologist may say it is 0.8. So we want a better projection of that finding. We need to do this OCT optic nerve head. So whatever measured and calculated there will be seen by everyone as that is the finding. Okay. Alright. So as for the management of glaucoma, in general, our main goal is to reduce IOP. So perhaps by reducing IOP, we can prevent further optic nerve damage and delay progression of glaucoma because there's no way of treat the glaucoma. Okay, we cannot treat or we cannot maksudnya we are treating but not treating to improve their vision. No, we cannot. Whatever the vision loss, the visual field loss, we cannot retrieve it back. It will be permanent, what we can do is that prevent further progression. Maksudnya prevent the further loss of visual field. Alright. So as we have medical, laser and surgery, most common in the open angle, usually kita akan bagi medical, which is our anti-glaucoma eye drop, and then surgery if it is not control ataupun ada progression. This is in the open angle. As for the closed angle, we need two, medical and laser most of the time. Surgery is the last one. So medical means because patient with angle closure, they will come with painful red eye in which the IOP will be as high as 50, 60, 70 or 80. So we need to bring down the IOP as fast as possible. So our medication is the acetazolamide or IV Diamox. Usually we will give it intravenously so that it will bring down the IOP very fast. And on top of that, we will give all the anti-glaucoma eye drops. Okay, and we know there will be inflammations in the acute glaucoma, acute angle closure glaucoma. Kita akan bagi topical steroids juga. And our aim for the acute angle closure is to open up the angle. Alright, so in the acute angle closure, because it is very shallow at the angle, so we will do a peripheral iridotomy. We will laser the iris, make a hole so that they will be bypass of the aqueous humor. Alright, and after that we will control with medications. And let's say still progressive despite all the medications, then only we'll proceed with surgery. So that's all. Alright, so the conclusion is that do not try to remember things but make them impossible to forget. So in order for that, I memang choose the topic, some of the topics that I presented may come out. Some of the topics will not come out at all, but it is very important for your life later on. Alright, and ask yourself throughout the day, what is important now? Only you know what is important for you. I cannot highlight it. Something may be important to me, but not important to you. So you are the one who can justify it. Alright. So any questions?
Pardon, doctor. I have a question.
Mm-mm.
For the patient like pediatric patient that they could have they could have come with congenital cataract.
Mm-mm.
So for pediatric patient, we usually don't change the lens, right? Because it will grow. They will grow. Like unlike adult, they can change the cataract without any problem. But for pediatric, they have some like you cannot change the cataract, right?
Yes. Okay. As the case for pediatric cataract, okay, let me tell you. If let's say you can detect at birth, some patients will have cataract at birth, right? So our aim is to remove the cataractous lens, the lens opacity, soonest at 4th week, latest at 6 weeks. But sometimes kita kena delay like up to 2 months or 3 months because of the condition lah. Maybe patient tak stable ke apa. But our aim is to remove the opacity. You are right, we cannot put the intraocular lens because so far we don't have intraocular lens yang made for pediatric age because we know the eye is growing. So what we do is that we take out the opacity, right? When we take out the opacity lens, the light can go inside the eyes. So dah tak ada, so kalau you nak check red reflex sekarang pun you boleh nampak dah. Okay, so bila dah clear, the patients will get all the light stimulus. And this will further macam stimulate the brain untuk nampak. Definitely the vision is not good. So what we do is that we will give the patients aphakic glasses, means cermin mata designed for those who don't have lens inside the eye. Aphakic glasses ataupun kita akan pakaikan dia contact lens. We will teach the mother or the parents to put on contact lens for the babies. So either these two. Alright. So by the age of 2 years old, usually the eye already reach good size, and the intraocular available, which is widely available yang kita guna untuk elderly, can be implanted already. So at 2 years old, kita boleh review back the patients and plan for intraocular lens implantations. So by doing it, patient dah tak perlu pakai FFK glasses dah. But one thing most important is that when we took out the lens, so it is not normal lens anymore, and we are putting intraocular lens, patients don't have accommodations. Sebab the lens is one piece sekarang kan, intraocular lens. So kita kena bagi glasses untuk dia tengok dekat. Sometimes kita akan bagi bifocal, depends macam mana. So we will see the visions during the follow up, and then kita akan advise the mother on the best treatment. That's why macam like elderly kena pakai cermin mata kan untuk tengok dekat kan, untuk reading. So got like that dah. Jadi budak kecil pun kalau dia dah buat cataract extraction, dah ada intraocular lens, dia kena pakai this reading glasses. Because what we give to the patient is usually distant vision. Okay, I hope my explanation is clear.
Yes, doctor. Thank you.
Okay, alright. Okay, just to elaborate more, if we detect the cataract late ataupun perhaps already macam like at 2 years old macam tu, usually patients already develop amblyopia. Okay, so kita boleh stimulate lagi after the correction bagi refractive glasses and all. But most of the time kita dah, even though patient dapat terang, but they don't get the stereopsis. So dia tak nampak 3D. Jadi kalau these patients, kita detect late, tak bagi correction awal semua, bila kita dah correct later on pun, macam umur 5 tahun baru buat operation, baru pakai glasses, apa semua, bila dia masuk cinema, they want to see all the 3D movie, 5D movies, they cannot appreciate what we are appreciating. Okay, what they see is just like plain 2D. Ataupun, so it will become blur for them. So definitely we don't want our patients to have that visions, right? So the best is it starts with you all, because you all will be the first doctors that will examine all the babies. Okay, especially at the ONG later on apa semua. So please, if you find it, refer it early. Okay, like I said earlier, as soon as 4 weeks ataupun 6 weeks, kita dah kena need to take it up. Right? Okay, any other questions?
Doktor nak tanya, kalau untuk ophthalmoscopy tu, before kita buat the examination, kita perlu mention ke macam I would like to letak eye dilator?
Tak payah. Dalam
payah?
kita akan dilate siap-siap dah untuk you
Oh,
all.
okay. Okay.
Okay, and okay, good for you to ask. Another one thing you have to adjust on the fundoscope, on the ophthalmoscope, is the light aperture to be used. Okay, because dia ada yang smallest point, dia ada yang bigger one, medium and the biggest. So in dilated pupil, always choose the biggest one. Okay, if the eye is undilated, choose the small one. Okay, but for you all, sebab we know you are not master student, so kita tak akan susahkan hidup you all pun. We want you to know the basic steps for you to examine. So kita akan dilate, we will make everything easy for you. So you just go examine and get the finding. Okay?
Okay, doktor.
Alright.
Doktor, saya ada soalan.
Mm-mm.
If yang pasal dial tu kan, kalau patient yang ada refractive error, should we correct also ke depends on us je?
Oh, tak payah. You tak payah nak correct. It depends on you. Sebab you will adjust the dialing lens kan? Sebab tu you kena put your index finger on the dialer.
So kalau kita VA kosong, patient ada refractive error, dial tu kat kosong juga kan?
Dial kat kosong. Sebab you
Oh,
cannot
okay.
ask the patient anything. You can't ask anything from the patient. You just have to perform it. So what you need to do, because you don't know what is the refractive error, that's why you have to adjust the focus. Even though if the patient tak ada power sekalipun, you still need to adjust the focus.
Thank you, Ada.
Doktor, nak tanya lah.
Ya.
Nak tanya kalau macam contohnya kalau yang doktor cakap tadi yang maculopathy tu dia boleh jadi non-proliferative dengan proliferative kan. Lepas tu kan the management for tu lain. So nak tanya kalau contoh patient datang with proliferative diabetic retinopathy with maculopathy tu, so kita still kena buat laser ke to that patient ke go to corticosteroid saya buat laser?
Kena. Sebab PDR tu lagi important juga. So untuk PDR, the treatment memang laser PRP. There's no other way to treat it. Okay, adjunct dia memang kita boleh bagi intravitreal anti-VEGF, but that is just adjunct untuk PDR. For PDR, memang the treatment is laser PRP. So if let's say PDR with maculopathy, jadinya you akan cakap you will do the PRP laser, the argan PRP laser, and then for the maculopathy, you can list whatever the treatment just now I showed you. Focal occlusive laser, intravitreal anti-VEGF, ataupun steroid, ataupun topical NSAID.
So maksudnya doktor maculopathy and maculoedema tu the same thing je lah doktor? Ke lain?
Okay, maculopathy is anything dot or blood hemorrhage or heart exudate on the macula. It's just that macular edema, you can only tell macular edema if we do like OCT. By looking, we cannot say any macular edema. Even ophthalmologists, we can only say clinically significant macular edema. So, but I'm not expecting you all untuk letak CSME. So for you all, you can say if let's say ada heart exudate, dot blood hemorrhage on the macula, mention it as with maculopathy. So the next question usually akan come up, what is the cause of poor vision in this patient? Okay, even though maybe dia dah cakap ada cataract, dia ni ada glaucoma apa semua, tapi dia highlightkan the fundus finding yang ada maculopathy, so you have to come up, the reason can be macular edema. Because we know this maculopathy is highly associated with macular edema. Okay tak?
Alright, okay, thank you doktor.
Alright.
Doctor, another question.
Terus yang tak ada question, boleh kalau nak leave. Siapa yang tanya boleh stay dulu.
Doctor, like for example, if we detect the baby had leukorrhea, leukocoria, so actually what is the first investigation that we will do to the patient, to the baby?
First investigation, you mean Ophtal, our side?
Initial management of the patient.
Okay, so in leukocoria, in the baby, usually first thing first kita akan buat dia, of course kita akan just tengok bedside examinations, but then we will examine the patients under anesthesia to look, to do like for the B scan, untuk tengok B scan ada any suspicious abnormalities in the vitreous and in the retina or not. Okay, because the causes just now boleh jadi ROP ataupun dia ada primary fetal vasculature yang masih remain ataupun these patients can have any retinopathy. So kalau dah ada cataract, definitely we cannot see the fundus, we cannot see any ROP. Kan? But in this scan, we can detect any finding associated with these conditions. And second, if we think it is highly if let's say the leukocoria, it appears leukocoria, but there's no cataract. Because bedside examination, we know there is cataract or not. Okay, so if no cataract, kita akan tengok ada finding apa-apa tak. If let's say ada finding macam RB, retinoblastoma and all, we will do MRI atau CT scan, okay, to look for the involvement, any scleral involvement, any optic nerve involvement, or maybe dia dah pergi extend to the brain macam tu ke tak. So always bedside examination to know whether it is cataract ataupun bukan. Okay.
Thank you, Doctor.
Mm-mm. Okay, any other question? Kalau tak ada, nak wish you all the best.
Thank you, Doctor.
Okay.
Yeah.
I hope
Thank you, Doctor.
Thank you,
Thank you,
doctor.
Doctor.
Thank you, Doctor.
Thank you,
Thank you,
Doctor.
Doctor.
Thank you, Doctor.
Thank you, Doctor.